My name is Doreen Schaefer, and I'm a nurse educator for the Johns Hopkins Department of Surgery, and I've worked as a critical care nurse at our Level 1 Trauma Center for over 34 years. I've been a member of the Johns Hopkins VTE Collaborative since 2013. I'll be reviewing the deployment of the Patient Education Bundle in response to a notification of a missed dose of VTE prophylaxis. Venous thromboembolism, or VTE, is comprised of both deep vein thrombosis, DVT, and pulmonary embolus, PE. Recent CDC statistics estimate that more than 100,000 people die each year. With the implementation of a targeted real-time alert and deployment of the Patient Education Bundle, we found a 43% reduction in the odds of non-administration and a 47% reduction in patient refusal of pharmacologic VTE prophylaxis. These fewer missed doses were associated with a 40% reduction in VTE events. So by executing this simple intervention, you too may contribute to a reduction of patient harm at your institution. The CLOTT project aims to implement a successful education bundled intervention to reduce missed doses of VTE prophylaxis at 10 trauma centers around the U.S. Following the algorithm, on documentation of a missed dose, a real-time alert will be sent to a designee, often a charge nurse, a pharmacist, or maybe another healthcare provider. The designee will then review with the documenting nurse, and interventions based on the specific reason will be employed. In the event of a patient refusal, the goal is not to force a patient's compliance, but to work with the patient and develop a plan that will minimize their assessed risk for VTE. A national survey of patients and families who were affected by VTE was done to prioritize topics and delivery methods for educating hospitalized patients about VTE. The results were used to develop this bundled intervention. The bundle includes a face-to-face conversation, patient education handout, and a 10-minute video. Sometimes scripts are very helpful in situations where a patient refuses. These can initiate conversations and emphasize that the ordered prophylaxis decreases harm while the patient is hospitalized. Loosely scripting interactions can be useful. Using phrases such as, "This is how we keep you safe." You can personalize your interaction. We look at your individual risk, or offer evidence-based information. The prevention methods that are recommended for people with your risk and health concerns are also adjust interactions for a patient's health literacy. Many patients come in with a perception that if they walk, there's no risk for VTE. At this time, there's no data that ambulation replaces VTE prophylaxis. Instead, emphasize the ambulation is an important addition to their VTE prevention, but it doesn't replace injections or mechanical measures. Discussion of ways we can help reduce side effects has also been helpful in patients' acceptance of their injections. Many patients, while fluent in English, find that having both their primary language and the English version helpful. Family may also like to review the education, and having it in the preferred language enables that engagement. There's 13 languages and large print for visually impaired available. For a complete list, you can access copies from the CLOTT website. Tailoring the discussion to your patient's specific risk factors is also helpful. The video was developed based on patient recommendations of who they wanted to see and what information they'd like to hear. Real survivors tell their stories of VTE and its aftermath. Providers discuss prevention, diagnosis, and treatment. It's helpful for the provider to watch the video. They are then able to address any questions that might come up. Every institution will be different and may access the video in different ways. This slide shows 2 links that can be used on either institutional platforms or on a patient's personal device. Links to the patient education materials and other resources are available on the CLOTT website on both the public-facing page and behind the password protection. Each institution should follow its own procedures related to refusal. A template for ongoing refusal should include education, notification, and documentation. Discussion with the patient in the event of a refusal should include other options for optimal prophylaxis. If the patient's condition is appropriate, are they eligible for a once-a-day shot instead of the 2 to 3 times a day shot? Would they wear SCDs or would they wear TEDs? The goal being the patient is ordered the best prophylaxis they're willing to receive. Other factors may contribute to missed opportunities for optimal prophylaxis. Following the arm on the right, we'll look into factors that may be associated with nursing and documentation. Patients may miss doses for reasons other than refusal. These reasons fall into these broad categories. At times, a missed dose is documented as condition not appropriate. Some acceptable reasons may include active bleeding, low platelets, drug allergy, heparin-induced thrombocytopenia. Notification of the prescriber in order to cover the hold or discontinuation, and ordering of risk-appropriate prophylaxis should be done. Unacceptable reasons include patients ambulating, patients going home soon, or patients asleep. The dose should be administered. At times, a missed dose is documented as not given due to concerns with the potential procedure. Acceptable reasons should be defined by prescribers or your institutional policies. Examples include neurosurgery and spinal taps or blocks. Reasons that may be unacceptable include surgeries where pharmacologic prophylaxis has been shown to be safe and effective in preventing perioperative VTE and may be given post-epidural placement but prior to incision. There are also cases where the intervention can be scheduled in relation to the dose so that the dose does not need to be held. Examples may include abdominal surgeries such as laparoscopic cholecystectomy, some interventional radiology or endoscopy procedures, and working with the procedural teams for things like epidural placement and PICC line placement. Before holding any dose, check with your institutional guidelines or contact your team to confirm and get a corresponding order placed. At times, a missed dose is documented as charted in error, duplicate order, medication discontinued, patient discharged, a temporary pause of the medication administration record, or unreviewed orders. Review should be done so that there's not a missed dose. The cells may be addressed by the documentation, but the medication is not actually administered. An example with a duplicate order, both cells are documented duplicate, but no drug is actually given. In the event a patient is not available, follow institutional policies to administer, if appropriate, prior to leaving the floor or within an appropriate time frame after return. Some institutional policies may include an algorithm that calculates a safe time to administer in relation to the next dose. Notification of a prescriber in the event of concerns with administration should be done with documentation reflecting the resolution. The algorithm is located in the CLOTT website for review. Ultimately, the goal is for patients to receive all appropriate prescribed orders, and if ongoing refusal, to tailor care to enable a patient to be given the best prophylaxis they're willing to receive.